I invite Dr. Shubhangi Bhave, madam. She is the president of SPOSI. She will be talking on getting good alignment outcome after a restrictive strabismus.
It's taking a minute. I just forgot to put it on.
Till the presentation is on, if you have some queries, you can please ask for any of the speakers. We have presented on esotropia surgery, exo, paralytic strabismus, and vertical strabismus. Now is the time for restrictive.
How is your experience with exotropia surgery in younger children versus a little older adults?
The alignment outcome, even the long-term alignment outcome in younger children is better than older children, especially if it's a long-standing squint. Especially beyond 35 years, you get recurrence.
Reverse. I find the younger children drift another in 10, 15 years, whereas the older children, meaning older adults, say at pre-marriage strabismus, stay for a very long time.
I usually have, long-term alignment is in pre-marriage children.
Uh, Very small children.
Usually for the children, extremely small children, we don't operate exotropia very earlier in life. Usually we do, but for children, they have a smaller eyes, so the surgical dose has to be reduced because you are likely to get more correction per millimeter versus in larger eyes, especially in adults.
Aim for a slight overcorrection in children.
5 prism diopters.
They're definitely trained to, but that if the slide becomes more, then they become monofixators.
Yes.
That is why the whole issue.
Yes. So, as in DVD, exotropias are always a headache to the operating surgeon. So, with this, now we come at the outset. Let me thank Dr. Rishikesh and AIOS for this session. I'll be talking on straight eyes after restrictive strabismus. I'm mainly covering Duan's, not the other restrictive strabismus. So as you all know, Duan's retraction syndrome is a type of congenital cranial degeneration syndrome occurring in about 1 to 4% of strabismus cases. It is characterized by variable limitation of horizontal ductions, narrowing of palpebral fissures, and up and down shoot of eyes. And the most accepted theory of is innervational, and then there are the mechanical changes in the muscle leading to tightness and fibrosis. Diagnosis, the most common diagnosis it is missed with is 6 nerve palsy. So the pointer is not working. Okay. So if you see in this girl, she has a grade 4 abduction deficit, a 6 nerve palsy with a primary position esotropia of about 30 degrees. But a similar lady with a grade 4 abduction in cases of Duan's has a straight eyes in primary position. So the primary position deviation is not in concordance with the limitation of eye movement. So that is one biggest differentiating point between a paralytic and a restrictive strabismus. Then we have these palpebral fissure changes, the pumpkin seed sign, and in this girl you can see primarily she's quite straight, but as she adducts her eyes, there is a severe retraction of the palpebral aperture, which is not seen in cases of paralytic squint. Yes, sorry. Then associated with paralimbal dermoids, preauricular skin tags. It could be familial. Now, certain tips in examination. One has to assess the anomalous LR innervation. That is the key to success in DRS surgery. So EMG is the gold standard, but EMG is not available everywhere. So we need to assess the LR abnormal innervation clinically. So clinically, how do we assess? Assess it by retraction of the amount of retraction. More the retraction, more the anomalous innovation. Up and down shoots, again they are severe, then LR is acting more anomalously. Then there's the forced degeneration test of Ramiro-Appice, which assesses the abnormal innervation of LR in adduction. And in Duans, in order to accurately measure the angle of deviation, we need to control the fixating eye during measurements. Now coming to the strategies in managing ESO-DR. In ESO-DRS, LR has minimal activity in abduction. They have anomalous LR action in adduction. One has to check for MR contractures by doing an forced junction test. And the trick is to do a minimal MR recession on the side of DRS, especially if co-contraction is more. Otherwise, it will lead to adduction deficit or even synergistic divergence in some cases. So if there is more deviation, we can even take the help of other eye in correcting the ESO deviation. We can plan asymmetric MR recession with SRT, IRT or partial VRT to improve the abduction, and Y split of LR if there is a significant up and down shoot. Now this is a case of ESO-DRS. You can see in the primary position there is an esotropy of 30-35. She has an abnormal head posture, and what we did is, since it was a large esotropia, we operated the right eye more, which was the normal eye. Left eye, we just did a 4 millimeter of recession. We have to do enough to just loosen the tightness of the medial rectus. And since, if you notice, she has a hypotropia in abduction. So since she had a hypotropia in adduction, we planned an IRT to a left lateral rectus muscle. So with this, the head posture also improved. The primary position esotropia also improved. There's some amount of abduction she could get, and the retraction in the adduction also became less. So overall, the patient was happy with the result. Now this is another child who came with an ESO-DRS. She had a head posture to the left. She had a right ET of, she had a very small ET, not much. Abduction deficit was there with narrowing of palpebral aperture on adduction. We did a left SRT with a left medial rectus recession of 3 millimeters, and post-operatively her esotropia and abduction doesn't improve fully, but small amount of abduction improvement is there. Now this is a video of superior rectus transposition. As we have discussed, one needs to clear the muscle till about 10 to 15 millimeters behind the insertion, and after tying the muscle with Vicryl, we're hooking the lateral rectus muscle, putting a Foster suture 8 millimeters behind, and then we need to suture the muscle along the side of lateral rectus along the spiral of Tilo. So in the same direction as the LR, and then the non-absorbable suture is tied. So then in EXO-DRS, again there is abnormal innervation to both medial rectus and lateral rectus. One has to estimate the co-contraction, estimate the LR activity. If exotropia is there with a normal LR activity, one has to do a LR recession. If it is associated with up and down shoots and retraction, then Y split of lateral rectus with recession, or supramaximal recession of LR, or if it is very severe, periosteal fixation of LR are the procedures recommended. Again, remember, there is a other eye which we can operate. Now this girl came with a large head posture. You can see a face turn to the right with a large exotropia, and abduction deficit was not too much. So I just decided to do a Y split of LR with other eye LR recession. So after this, doing 2 muscle surgery, the head posture got corrected nicely. Primary position exotropia was also corrected, and her retraction became less and there was no deficit abduction laterally. Now, this was an interesting case, Sujata. Just have a look, because I don't know if it was an exo-DRS, but it was a case of aberrant re-innervation. She had a large exotropia in the left eye with dense amblyopia. And just see this video. This was the pre-op video. There was an upshoot on adduction, and on abduction there was a downshoot. So it wasn't fitting into anything truly, but there was an aberrant innervation.
CCDD, one of them.
Yes, yes. So what we did was, we did a periosteal fixation of lateral rectus with transposition of superior rectus to medial rectus. And
How was the FDT?
FDT was, it was okay, not very tight. So, and this is post-operatively we could, and other eye LR also I recessed. So post-operatively the exo became quite okay, but the aberrant portion was not corrected well. So some cases, I don't know, we're not very, this portion, the downshoot remained or slightly exaggerated after surgery. I think I'll skip this video of Y-split. If we have time, then I'll show. Then strategies in ortho-DRS. Ortho-DRS, the main thing is you should not disturb the primary position parallelism. If there is a significant retraction in adduction, then only one needs to operate. I generally do differential recession of both LR and MR. Preferably one muscle on adjustable, so as to adjust for the primary position change in the deviation. And if there is a severe upshoot and downshoot, then we can do a Y-split of LR with MR recession. Now this was one case of ortho-DRS, primary position straight, but there was a significant lid retraction. So we did a left eye differential recession. So primary position ortho was not disturbed, but a retraction became less. So because it is important for young girls. Now this was a case of bilateral DRS, probably Mobius also she could have. There was a flat nasolabial fold and all that. And initially I suggested that we do a differential recession in one eye and see, but the parents were happy, and so they asked me to do the other eye after 2 years. So this is our team at Drishti, and we have our annual SPOCI conference in December 7th and 8th at Nagpur, so everyone is invited. Thank you.
Thank you, ma'am, for a wonderful presentation.
Thank you.
What has been suggested, especially about that superior rectus transposition, SRT,
Yes.
that the abduction partially improves. Even I have not seen improving it totally, but
Yes.
with time it tends to improve. That is
Yes.
what has been
Yes.
mentioned in the
SRT is a good procedure. Only thing is ki you shouldn't combine it with too much of MR recession. Otherwise it leads to an exodeviation.